I'm Sherry Boschert reporting for IMNG Medical Media at the American Psychiatric Association annual meeting. I'm with Dr. Gabor Keitner, who has a fresh approach to treatment-resistant depression.
The way we're approaching this population is not helping them. So treatment-resistant depression afflicts 20 to 30% of patients with depression. And it's associated with considerable medical, psychological, social morbidity. And there are no effective treatments available for treatment-resistant depression currently. And there are many different things that are being tried, but none of them seem to be particularly helpful. So the question then became, what do we do for these patients who are not responding to available treatments, who are given more and more variety of treatments which are still not helping them? What do we do with them? How do we help them to live with the reality of an illness that is so problematic and difficult for them?
So you started a program for these patients and did a pilot trial. Describe what you're doing.
Well, what we're trying to do is really common sense. And it's really not novel, except that we're applying it to this population. We're trying to utilize what has been learned from the management of other chronic diseases, such as diabetes, arthritis, hypertension, cardiovascular disease, cancer, and apply it to this population. And what we're trying to do is to acknowledge and validate the reality of the difficult illness that patients have, remove blame from the patients for having such an illness, remove blame from their providers for not treating them well enough, and then help them to set realistic expectations about the outcome of their illness. Clearly, these are not depressions that are going to remit. On average, the patients who we see with treatment-resistant depression have had depressions for over 20 years. If they had a kind of depression that was going to remit with treatment, they probably would have remitted by now, and patients are aware of this. So we help them to set realistic expectations, meaning that we can help them to recognize that their symptoms could be alleviated, but not eliminated. And we help them to focus instead on how they can function in spite of having symptoms, how they can focus on coping more effectively, how they can improve their relationships, their meaning in the world, improve health habits, sleep, exercise, diet, common sense things that most of us would benefit from, but don't apply systematically. So I think we take away the focus from the illness and the symptoms of the illness to focus in on who they are, what are their lives like, and how can they live it in a more fulfilling way so that the illness and the disease does not define them. Well, we've learned a number of things from this study. One is that a fair number of patients with treatment-resistant depression have personality disorders, particularly borderline personality disorders. And we are going to include a number of modules in this new iteration of our disease management program that helps patients to manage the stress tolerance and the moodiness that comes with that personality disorder. We've also learned that perhaps 9 sessions is not sufficient for people who've had depressions for over 20 years. And we're going to increase the number of sessions to 16, which is more the common number of psychotherapy sessions for depressed patients. And finally, we're going to include a telehealth component, meaning that we're going to find a way through telehealth capabilities to have some of the sessions that these patients are engaged from their home. Because some of these patients are so depressed, in the beginning they have a great deal of difficulty even getting themselves out of the home to make treatment sessions. So I think we're going to be testing this on a larger number of patients with modifications that came out of what we learned from this study.